Milind, can we start?
Yes, sir.
Okay. Good morning. So we are having a new class schedule starting from today. So we'll start with hernia for this month. We'll discuss different types of hernias. Today the case will be presented by Dr. Milind Alokji. He is a second year junior resident at MR Bangur Hospital. And today our teacher is Dr. Gautam Das. He will take us through the scenario. I will repeat him. So Milind, you can start presenting the case. Have a look at the hernia site of the patient and then start describing. Just show the area of the hernia. Just have a look at the patient, his hernial site.
He's presenting the history, I suppose.
Yeah.
He has got a mobile as well.
Oh, yes.
He has got a mobile with him. With that, he will be showing us the patient.
Okay.
That's
We will
his
be trying
strategy.
to have a fixed camera.
He's
right?
trying to do, yeah. He's
Side
trying to
visible?
do.
Yeah, Milind.
So is the site of the hernia visible?
Yeah, the slide is visible, Milind. We will need you to show us the patient once. That's what Dr. Shah is asking. Hello, Gautam.
Yes, yes, madam.
The video to off.
Ma'am, is it visible now?
Oh,
Yeah,
What?
just
Yeah,
closer,
the patient is visible. The patient is
closer,
visible.
closer. We can't see the hernial area. No, actually we are seeing more of the room.
Milind,
And,
Milind.
no, I
Take
can see
Sir, it is
the
on the other
hernia side.
screen, sir.
I can
No,
see the
Milind,
hernia side.
Milind, please take the camera near the inguinal region. We are not able to see that.
No,
Ma'am,
I can
Is
see
your-
the inguinal region.
Oh,
it
we
is
are
on
not-
the other screen. There is another screen that I've joined from.
yeah.
আচ্ছা তো আমরা কোথা থেকে পাবো
I can see this.
ওকে we are not দেখছি দাঁড়াও হ্যাঁ 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 মানে আমাদের এটাতেও আমাদের মোবাইলেও ঘোরাতে হবে হ্যাঁ এবার দেখতে পাচ্ছি
Yes.
Milind, we are able to see but then মানে we can't I don't know how to change it.
Okay, Milind, when we'll be asking you to demonstrate some clinical method, let somebody else focuses the camera and
Yes,
you
sir.
do the method. Okay,
Yes, sir.
start presenting the case. Fine.
Yes.
You start presenting the case and then wait at the end of presentation. We'll have some questions and then go for examination.
அவரு கூட சொன்னார்ல இன்னைக்கு
Start.
ஆமா நான் ஒரு ரூல்ஸ் தான்
So is my screen visible?
Yes.
Yeah.
Yes, sir. Good morning, sir. I'm Dr. Milind Alokji, second year DNB PGT at MR Bangur Hospital, and I'm going to present a case of a unilateral inguinal hernia in an adult. My patient, Mr. N, 68-year gentleman from Tollygunj, Kolkata, who is currently unemployed, came with the chief complaints of swelling in the right groin and scrotum since the last 2 years, and intermittent pain at the same site since the last 2 years. History of present illness. The patient was apparently well when he noticed a small swelling in the right groin about 2 years back. The swelling appeared spontaneously in the groin region and gradually increased to the present size of about 4 into 7 centimeters, extending towards the scrotum. The swelling became prominent on standing and walking and disappears on its own when the patient lies down. The patient gives a history of work involving lifting heavy material and prolonged standing 2 years back at the time the swelling first developed. The patient does not give a history of any swelling on the opposite side. A patient complains of aching pain over the site of the swelling ever since he first noticed the swelling. The pain increases when the swelling is prominent and decreases when the swelling subsides, as when the patient lies down. Patient is a former smoker and has stopped smoking since the last 3 years. There is no history of long-standing cough or COPD, no history of chronic constipation. The bladder habit is normal and there's no history of dysuria, hesitancy, urgency, frequency, or acute retention. There is no history of fever, severe pain with redness at the site associated with vomiting or constipation, and there's no sudden increase of the size of the swelling. There is no history of similar illness in the past, no history of any previous surgeries on the same site, no history of any other surgery in the past, and no history of any major illness in the past. The patient, or personal history, the patient consumes a mixed Indian diet, has no comorbidities, the sleep and appetite are normal, and has no history of allergy to any food or drug. There is no history of similar illness in any member of the family. Summary of the history. A 68 years gentleman presented with a swelling in the right groin and scrotum about 2 years back. The swelling appeared spontaneously in the groin region and gradually increased to the present size of about 4 into 7 centimeters, extending towards the scrotum. It becomes prominent on standing and walking and disappears on its own when the patient lies down. The patient gives a history of work involving lifting heavy material and prolonged standing 2 years back at the time the swelling first developed. There is no history of any swelling on the opposite side. Patient complains of aching pain over the site of the swelling ever since he first noticed the swelling, and this pain increases when the swelling is prominent and decreases when the swelling subsides, as when the patient lies down. So should I proceed with the...
No, wait.
Milind, yes,
Yes, sir.
Milind,
Yes,
you haven't mentioned a very important part of the history, whether there is any straining factor or not.
no, so the patient, on asking whether
It
the
is very
patient...
important. If you miss it, you may not pass the exam.
No, you just emphasize those points. You said patient does not have a cough, breathlessness. So you have to.
He does not have
more.
any... He does not have any history of chronic constipation, any long-standing cough or COPD, sir.
And urinary.
And sir, there are no urinary symptoms. The bladder habit is normal, sir.
It is very important. What is the age of the patient?
68 years, sir.
Yes. So you must have mentioned the urinary symptoms. Why?
Sir, because there can be, in this age, sir, there can be prostatomegaly, and that is a persistent staining factor, sir.
Yes, you have to, patient may not tell that, but you have to deliberately ask the question, leading questions.
Yes, sir.
Regarding
So
urinary
when you
symptoms.
summarize, when you summarize at the last point in summary, should mention that line.
Okay, sir.
You have mentioned in history present illness, but when you summarize, in summary, that point should come. Patient
Okay,
does
sir.
not have any chronic staining factors like cough,
Like
breathlessness,
cough, constipation, breathlessness,
constipation,
or urinary
or
tract.
any urinary symptom.
Yes, sir.
Okay, that line should be there in the summary.
Okay, sir.
Another important factor you should tell in your, as a postgraduate students, that whether there is any attack of irreducibility within this period, whether for some period he got admitted or there is irreducible with pain and
No, sir, there
subsequent-
was no such history, sir.
Okay, then
Go to
proceed.
the past illness, Milind. Go to the past illness.
Yes, sir.
Yes.
Often students mention in their history there is no history of similar illness in the past.
Yes.
He complained of a swelling in the right groin, which is
Yes.
extended to the scrotum.
Hmm.
So either the swelling might have been operated earlier.
Yes.
There
Yes,
is
sir.
no chance of this having a spontaneous resolution. This line
Okay.
is applicable. This particular statement is applicable in diseases where the disease is characterized by relapse and remission, like
Okay, sir.
Barthel's disease,
Yes,
like
sir.
hydroxycosis.
Okay,
So
sir.
you cannot say somebody having a CS stomach, you cannot say he has no similar illness in the past.
Yes, sir.
Yes.
In that case, details of that previous illness will come. So this line
Okay, sir.
should be avoided in situations where the swelling which is coming up and there is no question of it getting resolved spontaneously. So this
Okay,
line
sir.
will not come in any other clinical presentation also.
Okay, sir.
Okay.
Yes.
So the hernia, Dr. Dash has already said that the most important part, apart from the swelling, is you have to touch on the points, particularly patient having 60 plus. You should be very cautious to ask about minor symptoms of prostatic enlargement.
Yes, sir.
Nocturia, then increased frequency,
Yes, sir.
this patient having hesitancy or urgency. They are all
Yes, there were
important.
no such, yes, sir. There were no such symptoms, sir. The patient's bladder habit is normal, sir.
I think you can pass on to the examination part.
Yes. Yes.
Yeah.
General examination. The patient was examined after taking informed consent in a well-lit room and with proper exposure. Was examined both in standing and supine position. The patient was conscious, alert and cooperative. Karnofsky performance status is 90. Build is average and decubitus was of choice. The BMI of the patient is 21.5. The vitals, pulse rate was 86 beats per minute, regular in the right radial artery. Respiratory rate 15 per minute. Blood pressure was 122/82 millimeters of mercury in the right arm in supine position, and temperature was normal. There was no pallor, icterus, cyanosis, clubbing, generalized lymphedema, lymphadenopathy, or edema. Inguinoscrotal regional examination. Inspection in the standing position. On the right, in the right side, its scrotal region, we see that a swelling is present. The swelling extends from above from the middle of the inguinal region into the scrotum, but does not reach its bottom. The swelling is about 4 into 7 centimeters in dimension, has a smooth surface and rounded margins. Expansile impulse on cuff is seen, and the skin over the swelling is normal. There is no visible peristalsis over the swelling, no deviation in position of the penis, and the testes can be seen separately from the swelling. The left-sided inguinoscrotal region is normal. Palpation. On the right side of the scrotum, inguinoscrotal region, local temperature is normal. There is no tenderness noted. It is not possible to get above the swelling. The shape is pyriform, size 4 into 7 centimeters. The swelling extends from the inguinal ligament to the upper pole of the right testes. The swelling was smooth with well-rounded margins and doughy consistency. Expansile impulse on cuffing is palpable. The swelling can be reduced back easily, and the testes is palpable separately from the swelling. The deep ring occlusion test is positive and the invagination test is not done. The left side of the inguinoscrotal region was normal. Percussion. A dull note is heard over the swelling. Auscultation, there were no bowel sounds heard. Per rectal examination, the tone is normal, stool was present, and the prostate surface is smooth, with the upper border of the posterior surface can just be felt with the tip of the finger. Tone of the abdominal muscles was good. Systemic examination was essentially within normal limits. Gastrointestinal system, per abdomen was soft tender. There was no agonomegaly and no free fluid. Respiratory system, nominal vesicular breath sounds were heard. CVS, S1, S2 were heard. CNS, there were no focal neurological deficits. Summary of the case, a 68-year gentleman presented with a swelling in the right groin and scrotum about 2 years back, which appeared spontaneously in the groin region and gradually increased to the present size of about 4 into 7 centimeters, extending towards the scrotum. It becomes prominent on standing and walking and disappears on its own when the patient lies down. The patient gives a history of work involving lifting heavy material and prolonged standing 2 years back at the time the swelling first developed. The patient complains of aching pain over the site of the swelling ever since he first noticed the swelling, and the pain increases when the swelling is prominent and decreases when the swelling subsides as when the patient lies down. The patient does not give any history of any chronic straining factors such as chronic constipation, cough, breathlessness, or urinary tract symptoms. On examination, a right-sided inguinoscrotal swelling is seen extending above from the region into the scrotum but not reaching the 4 into 7 centimeters. It has smooth surface and with the expansile impulse with cuff seen and no visible peristalsis over the swelling. On palpation, the swelling is reducible easily and the deep ring occlusion test is positive. So should I?
Yeah, give the diagnosis.
My provisional diagnosis is this is a case of a 68-year gentleman with a right-sided reducible incomplete indirect inguinal hernia containing omentum without any features of complications at present, which I, using the European Hernia Society classification, I would like to provisionally classify this as a PL2.
And W?
Sir? So,
W.
Two.
Wait.
So, 2, sir. W2, sir.
Okay.
Now, you have told that this is you cannot get above the swelling. You can show me how
yes,
you
sir.
have tested
How
this.
do you do this test of
Yes,
getting above the swelling?
Sir, just a minute, sir. I'll shift to the other device.
Will you, Milind, will you do this test if the swelling is confined only to the groin?
No, sir. If the swelling is confined only to the groin, we don't have to do this test, sir.
Yes, this test
Only
is
when the
done
test,
to differentiate between what?
sir, whether it is so this is basically to differentiate whether the swelling is it is a groin swelling or it is an inguinal scrotal swelling, sir.
No.
No, just
So
scrotal
as in
swelling.
the origin is from the scrotum, sir,
No,
or from the groin?
it is to differentiate a scrotal swelling from an inguinoscrotal swelling,
Inguinal,
not
yes.
inguinal from inguinoscrotal. We differentiate a scrotal swelling from an
Inguinal
inguinoscrotal
scrotal
swelling.
swelling.
Yeah.
Yes.
Just have a try that. You can show us the
Yes, sir.
method to examine for getting out of the swelling.
I'm just arranging for a glove, sir. Can
Okay, it will take time. Just show us without gloves.
just okay, sir. Okay.
Then suppose you cannot get out of the swelling, what will be your inference?
Sir, is the other screen visible?
Other skin is not visible.
না, it is visible. মাখনদা অন্য মানে একটু তোমাকে সোয়াইপ করতে হবে।
তাই?
হ্যাঁ হ্যাঁ, একটু তোমার ফোনে সোয়াইপ করো তাহলে পেয়ে যাবে।
আচ্ছা।
It is visible, but a finger is coming in the camera.
Yeah. So show
Yes.
the method. We can see that swelling is extending up to the upper pole of the testis. So what is that statement called as not possible to get above the swelling?
Yes.
We start from the bottom of the scrotum and then we go palpating upwards, sir.
You have to do it simultaneously on both sides with your both hands, so that you can compare. Hello.
So
Yes, sir.
what do you feel in the root of the scrotum? What do you feel in the root of the scrotum on the right side?
Sir, on the right side, I can feel the swelling, sir.
Yes. So the swelling is still palpable at the root of the scrotum.
Yes.
And spermatic cord cannot be felt. That
Yes,
means
yes.
swelling is extending above, beyond your finger at the. You need not go to the groin. You palpate up to the root of the scrotum.
Yes. What are you palpating on your right with your right hand? What structures you are getting on your right hand? With your right hand,
I can feel the spermatic cord, sir.
yes, you can palpate the spermatic cord and 2 folds of skin.
Yes.
And on the left side, there is something other than these, isn't it?
Yes, sir.
Yes. So what is your inference?
Sir, this is an inguinal scrotal swelling, sir.
Inguinoscrotal swelling. So what are the inguinoscrotal swelling commonly we can see?
Inguinal hernia is the most common inguinal scrotal swelling that we can see.
Yes, other than inguinal, other than hernia, any other inguinoscrotal swelling we can get?
Sir, a congenital hydrocele, sir.
Congenital hydrocele, very good. And any other type of hydrocele?
Sir, an incision of the cord.
Yes, infantile type and congenital type. Congenital type, there is a communication. Infantile type, there is no communication with the peritoneal cavity. And another thing you should mention, if you asked by the examiners, this varicocele. In varicocele also, you will not get above the swelling.
Okay.
Okay. Then what is your diagnosis? Hello.
Yes, sir. Yes, sir.
Yes, sir. Got the points?
Yes, sir. Yes, sir.
Yes. What is your diagnosis finally?
Sir, my diagnosis is hello.
Yes.
Yes, sir. My diagnosis is that this is a 68-year gentleman with a case of a right-sided, reducible, incomplete, indirect inguinal hernia containing omentum without any features of complications at present. which I classify as a primary lateral 2.
Yes. Then why you are calling this swelling as a hernia?
Sir, by definition, a hernia is a protrusion of a viscus or a part of
No,
a viscus.
you cannot see it with laparoscope or something like that. That is pathological diagnosis. Clinically, why you are calling this swelling a hernia?
Sir, I'm calling this as a hernial swelling because this is a swelling in the inguinal region.
No, hernia may be anywhere, may not be in the inguinal region also. What are the criteria for a swelling to be a hernia?
Sir, it is
Anyway.
reducible, sir. A cough impulse is
Yes.
present.
Yes.
Sir, it is reducible and an expansile cough impulse is present. Sir.
Yes, yes. Then you are correct. Okay, you have to sell these 2 points to call a hernia. It may be anywhere.
Okay, sir.
Okay. So, can you whether you are calling it reducible? Can you show us?
Yes, sir. Sir, we will ask the patient to first of all, we'll ask the patient to go into a supine position, sir.
Yes.
We'll ask the patient to get into the supine position. First thing that we will ask the patient to reduce the swelling on his own.
Keep the camera close.
Sir, if the patient is not able to reduce the swelling on his own, then we will first of all flex the.
No, whether you have told that it is disappearing on its own. Is it?
Yes, sir. The patient initially earlier had a history where on lying down, the hernia used to subside on its own. But sir,
now.
Sir, now it reduces in size, but it does not completely reduce.
Yes, that is the price. For that, I want to see it. Because your presentation should be what is the findings on the day of examination, not in the past. So it is contradictory because so large hernia, you have told it an indirect hernia, so large hernia passing to the scrotum, and it is getting reduced just after lying down. It is not matching. Usually, direct hernia spontaneously reduces whenever the patient lies down. Okay, so you should be very sure whether it is being reduced spontaneously. In case of when you are telling a inguinal hernia and reaching up to the scrotum.
Yes.
Okay. So then, if it is not reduced spontaneously, what will you do to see its reducibility?
So first, we ask the patient to the patient
Yes.
is not in his own. Then we try to reduce the swelling by the method of taxes.
Yes. Can you show it?
Yes, sir. So we ask the patient to be in the supine position.
Yes.
We ask the patient to we ask the patient to flex the.
Reduce corpo.
We'll ask the patient to flex the joint at the hip and the knee. And once that is done, sir, I'm standing on the right side of the patient with my left.
Yes. And you have to adapt the hip also.
Yes, sir. The leg will, sir, and
then
right hand I will place over the swelling and I will slowly try to reduce.
Swelling, the bottom of the swelling.
Yes, sir.
Okay. Yes. Then your left hand will direct the swelling towards the inguinal canal.
Yes.
Okay. So it is reducible, and then you can test the cough impulse again. Okay. So it is a hernia.
Yes.
Okay. But you have told it is an inguinal hernia, isn't it?
Let him demonstrate the deep occlusion test. Milind, you demonstrate the deep occlusion test.
That will come later.
Okay.
You have he has told that it is an inguinal hernia. So why it is not a femoral hernia?
You can see this swelling pubic tubercle. It is above and lateral to the pubic.
Above and medial. Inguinal is above and medial pubic tubercle because it has gone to the scrotum.
Yes.
A femoral hernia will not go to the scrotum.
Yes.
The hernia has gone to the scrotum, and in relation to the pubic tubercle, the hernia is where?
So in relation to the pubic tubercle, it is so medial and above.
Yes.
How you have found the pubic tubercle?
Sir, we find the pubic tubercle for that. So first of all, we have to identify the pubic symphysis. Sir, we start at the umbilicus, and in the midline we go down. The first bony point that we feel is the pubic symphysis. As we go laterally from the pubic symphysis, we will see that the prominent bony landmark we will find, and that is the pubic tubercle.
Yes,
Alternatively,
that is good, but yes, as Professor Shah is trying to mention, it is good, but if there is a large sac, hernia sac, passing medially over this pubic tubercle, then you cannot find it. Okay. Because you are pushing, coming from the symphysis pubis towards the pubic tubercle, and you have told that it is above and medial to the pubic tubercle. So you may not get it. Then you should know the other methods to find it also. What are the other methods?
which tendon is attached to the pubic tubercle?
So the adductor longus, sir.
Yeah. So how do you make it taut?
Longus upward, and we reach the pubic tubercle on making the adductor longus.
So he will attack the thigh against resistance. Attack the thigh against resistance. Ask him to attack the thigh against resistance and feel the tendon medially.
जिस तरफ हाथ है ना उस तरफ धक्का दीजिए.
Yes.
No, place your right hand medially. Yes. Now it is correct.
You can clearly feel the tendon on the medial side of the thigh.
Close to the pubic tubercle. Go closer and you can palpate. Go closer, much closer. Yes.
Pubitical intervention is important for hernia examination. To look for the relation of hernia to the pubic tubercle, to find the deep ring also you need to either use pubic tubercle or symphysis pubis. Okay.
Okay. There is another method also, passing from anterior superior iliac spine along the inguinal ligament. Okay. So it is the inguinal hernia. Now, you have told it is an indirect hernia, isn't it? So, what test you have done to show that it is an indirect hernia?
Sir, to show that it is an indirect hernia, we have done the deep occlusion.
Yes. How you have done it?
Sir, first of all, the patient.
You describe the steps for doing a deep occlusion. What are the steps? First of all, patient should lie down. Number 2.
Sir, we will mark the pubic symphysis, the anterior superior iliac spine. We will see we will identify the midpoint between the pubic symphysis and the anterior superior iliac spine. This is the meeting 1 point, sir.
Before that, what Professor Shah is asking, what you have to do? You have to reduce the swelling.
Yes, sir, reduce the. Yes, sir, we have to reduce the hernia.
Yeah.
Yes, so reduce the hernia and then mark the points. Then at this point is the deep inguinal ring. After hernia, we place our thumb over the deep inguinal ring and we ask the patient to cough. If the hernia develops, if the hernia appears medially to the deep inguinal, if the hernia appears medially to our finger, then that means that this is a positive test, and
No, it's not positive test.
negative
not
test. It's
positive.
negative
It is
test, then that
negative.
is the direct inguinal hernia. And if it does not appear, then it's a positive test, and that is the indirect inguinal.
Yes, you have to be very clear regarding this. Okay. And again, you have to release the thumb, ask the patient to cough. Yes, so that it is better, you have to place the thumb and ask the patient to stand and then try it again. Okay. And again, after releasing it, you have to ask the patient to cough, see whether it is coming out or not. In case of whether deep ring occlusion test is positive. Okay, what are the other methods? Do you know that you can see that it is, though may not be done every time, to say that this is an indirect hernia, not a direct hernia.
You said you have not done the test. What is that test?
The nation test, and one is the Siemens deep finger test, sir.
Initiation is not done because it's painful.
The
And,
imagination test is not done, sir, because it is painful to the patient. And sir, the Siemens three-finger test may also not be done because in that we use the three fingers to occlude the deep, the superficial, and the femoral ring, and we might not be able to clearly identify the sensation in that particular test, sir.
No, actually, Siemens test is done in case of very small hernias, not such a large hernia. Okay. And how it is done? Can you tell that with the what will be the position of the patient and where will you, what is the position of the examiner?
Sir,
it is not written in many books, but in some
sir,
books it is written.
Sir, we use three fingers to occlude the three rings.
Yes,
our index
but
finger.
what will be the position of the patient?
The patient will be supine, sir. Patient
No.
will initially be supine, sir.
Patient will be standing. And where you will stand?
Sir, we'll on the side, stand on the side of the hernia, sir.
No, you will stand on the back of the patient and more towards the side you are examining. Suppose this is a case of right-sided inguinal hernia.
Yes,
you have to examine on the back of the patient more towards the right side so that you can use your right hand freely. Similarly, on the left side, you have to go more towards the left side and use your left hand. Okay. Though this is not easily not done
in
every
exam,
case, but you have to know it.
It's not advice now. Okay. But you should know the method, how it's being done.
Yes.
Okay.
So it is then indirect inguinal hernia. You have another thing you have told that it is it contains what contains omentum.
Omentum, sir. Yes, sir.
Omentum. How you are sure that it is the omentum? What
So
are the features? Starting from the history. What are the difference between a omentocele and enterocele?
Sir, an omentocele is when the omentum is the content, and an enterocele is when the.
If it is the enterocele, what
it is by
patient can tell you? Sometimes patient can volunteer.
Yes.
That while doing reduction, he can hear
a gurgling sound, sir. He will hear a gurgling sound.
Before that, in the history, omentocele is usually not completely reducible. As you have told that it is totally reducible after lying down.
Yes, sir.
In most of the cases of the omentocele is not completely reducible. Okay, is from the history. Then come to examination.
Sir, on examination, in case of an enterocele, a visible peristalsis might be noted.
Yes, on
swelling.
inspection. Yes.
On inspection, a visible peristalsis might be noted over the swelling, sir. In case of palpation, sir, while we are reducing, in case of an enterocele.
Before reduction, Is there any difference in consistency? You have not
Yes, sir.
mentioned it.
Sir, the enterocoel is soft and elastic, whereas omentum is doughy. Sir, yes, sir. So while reducing, in case of an omentocele, initial reduction is difficult and then it is easier. While in case of an enterocele, initially it is easy and the later part is difficult.
No,
No.
you are saying
Just the
reverse.
reverse. Just
Sorry,
the
sir.
reverse.
Sir, in case, yes, sorry, sir. Enterocele, the initial part is difficult and later is easy, and omentocele initial is easier and later is difficult, sir.
Why?
So, because in case of an enterocele, initially the bowel might be filled with gas, and sir, so it is once it is one that
Gas and liquid also.
gas and liquid, sir, and once that is reduced,
intestinal
once that
content,
is
yes.
removed and the contents are emptied, which is generally reduced with a
Yes,
gurgling
first
sound, it is easier to reduce. In case of omentocele,
Yes.
sir, initial part is easier to reduce, but the latter part might be having adhesions to the sac, and that is
Yes.
why it becomes difficult to reduce, sir.
Yes, good. So you keep in your mind the reasonings, then you will not be wrong.
Yes, sir.
So it is and auscultation also.
On auscultation, the bowel sounds might be heard in case of an enterocele.
Yes. 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 So that is a, and you have told it is an uncomplicated.
Yes, sir.
Because it is reducible now.
Yes, sir.
If it is reducible, then you don't have to mention any other thing, whether it is uncomplicated or complicated.
Okay, sir.
Okay. Now you have told it in your right side, no? Right side.
Yes, sir. Right.
Inguinal hernia. Why it is in which side it is common, right or left?
On right side, sir.
Why it is common on right side?
Sir, because on right side the testis descends later and the processus vaginalis is patent for a longer duration, sir. So that is why it is more common on the right side.
Yes, very good. And femoral hernia is also common on the right side. Why? Do you know?
No, sir.
Okay, proceed.
Yes, sir.
Then how will you manage this patient?
Sir, in this condition, sir, the diagnosis is a clinical diagnosis, sir. We can clearly see it's a hernia. So, sir, my intervention in this case would be I would like to go for a surgical intervention. But
in this case, I think you should do one investigation.
Yes, sir. So before proceeding
not
for
suggestive.
Yes, sir.
Okay.
So
investigation for confirmation of diagnosis is not required.
Yes, sir.
He being a 68-year-old gentleman, even if he has no prosthetic symptoms, he has to
USG KUB plus PVRUs.
Yeah.
Yes.
Yes, sir.
Yes.
So we do not require an investigation to confirm the diagnosis, but we will require investigation, ultrasound KUB plus PVRU to ensure that there is no prostatomegaly. Then, sir, we will further we will
not only prostatomegaly. Prostatomegaly is not the way. PVRU is important because you want to know the obstructing factor. Yes, prostate may not be very large in case of obstruction. Okay. I mean, a very large prostate may not produce any obstructive symptoms. So you have to do the PVRU. And what is the ideal investigation in this age? For any bladder outflow obstruction, you want to know?
Sir, uroflow.
Yes.
Uroflowmetry, sir.
Uroflowmetry is the ideal. Okay. Proceed.
Uroflowmetry, sir. So then we will get investigations for pre-anesthetic fitness and to check whether the patient does not have any other systemic illnesses.
That is enough. Okay. Then proceed.
Sir, I would like to go for a surgical intervention, sir. So the options available as per level of expertise.
What's your choice? It's not option.
Sir,
what's your choice?
I would like to go for a Lichtenstein tension-free mesh hernioplasty, sir, an open repair.
What is the current recommendation? What is
the current recommendation is for unilateral inguinal hernia in an adult, we can go for a laparoscopic repair.
Provided
the level of expertise is there, sir.
Yes.
Yes.
So with a lot of publications now, Liechtenstein is considered the gold standard surgery for open repair. But
Yes, sir.
if the expertise is available, why laparoscopic surgery is graded superior to Liechtenstein?
So because so it is one, it is minimally invasive, sir.
What is the main point in favor of laparoscopic repair?
so when we go for a laparoscopic repair, we not only we can together repair, we place the mesh on the entire myopectineal orifice, sir, so that prevents any further recurrence of other hernias as well.
The main reason is chronic pain.
Yes.
You see, chronic
So,
pain.
so you know what are the complications of hernia, as you have told, is
Yes, sir.
uncomplicated. But as Professor Saha has told previously, told also of course, it is common complications are all this recurrence this previously. But nowadays, after Liechtenstein, recurrence is very rare. But present day complication of open hernia surgery is the pain, persisting chronic pain. That is the important. It has replaced the recurrence as a common complication. So for that, this posterior approach or this laparoscopic approach is better because it is not interfering with any nerve that causes pain. Okay.
How do you define chronic groin pain?
Sir, chronic groin pain, sir, pain persisting for more than 6 weeks that interferes with the daily activities or the usual activities of the patient, sir.
Chronic groin pain.
Sir?
What do you mean by chronic groin pain after hernia surgery? When do you
Chronic groin pain is defined as pain that is persisting even more than after 6 weeks after the surgery and is preventing the patient from doing their usual normal daily activities without any
cannot be so
discomfort.
severe. No, it is not that you have to interfere with the daily activities. It's a persistent pain, persisting more than 8 to 12 weeks following hernia surgery. It may not interfere with daily activities, but it's a nagging pain. Okay.
Yes, sir.
So it is said that early return to work,
Yes,
discharge from the hospitals are almost comparable with the lap and open hernia.
Open.
The initial pain score may be almost identical to lap and open hernia.
Yes, sir.
In lap.
So you muted, sir.
Yeah. Suppose this patient, we will discuss prostate in a different case scenario. So you can have some discussion on hernia, theoretical part, Dr. Das.
yes.
10 minutes time.
So what are the types of hernia? You have told one classification. There are other classifications also. But what are the other classification of hernia according to the progress?
So, NIHA's classification is there, sir.
No, this is the classification. There is several other classifications. Now, what are the other types of according to the progress? As far as it is very small. If it is within the inguinal canal, what it is called?
Oh, sir, bubonocele, sir.
Yes.
Yes.
Then,
and sir, if it is at the upper pole of the testis, is known as a funicular type, and then there is a complete hernia, which is at the base of the scrotum.
yes, no, complete, yes. Complete definition there differs in books to books. Some tells it, if it is crosses the superficial length, then it is complete. In some books, it is written that it should reach the bottom of the scrotum.
Yeah,
So
complete bottom scrotum and scrotum testis is not felt
Not
separately
felt.
from the hernial side. That is the definition of complete now.
Yes.
Okay.
Now, suppose this you got a strangulation. You have told that you will do it by Liechtenstein, tension-free with mesh.
Yes.
But is there any indication nowadays for this just tissue repair without using mesh?
So, so if we are, yes, sir, if we are using another technique such as the disorder repair, sir.
No, in situations where you may have to go for a.
Sir, if it is a strangulated hernia, sir, and
Yes,
when the site
yes.
is contaminated, then
And you have
we
to,
might not put the mesh, sir.
yes, you have to go for resection and anastomosis.
Yes, sir.
So you should be conversant with the
Tissue
other
repair.
methods also. What are the other methods for repairing just using tissue and so-called hernia or raphy? What are the
Sir,
methods? Do you know?
so shoulder repair is there, sir. Modified Bassinis is there, and Pesarda method is there, sir.
Yes. What is Bassini?
So, in case of Bassinis repair, sir, we bring together the conjoint tendon and the inguinal ligament. We repair the posterior wall defect by bringing together the conjoint tendon with the inguinal ligament, sir. Modified Bassini, sir.
Yes. And
Intermittent sutures.
any.
Intermittent sutures opposing the
Yes,
conjunctiva inguinal ligament.
inguinal ligament.
Milind,
And
one
Yes,
question
sir.
back. You said hernia is a clinical diagnosis and you don't need to have any investigation. Can you
Yes, sir.
tell me a situation where you need to do investigation to confirm diagnosis of hernia, groin hernia?
Occult hernia, sir.
Occult hernia means?
Sir, when the so it's sir when the patient is complaining, sir, but clinically the hernia is not very evident.
One. Second is patient presenting the groin pain. Patient with groin pain, you suspect hernia, but clinically hernia is not discernible.
Not, yes, sir.
Second is patient who are obese. In obese patient, it is difficult to make out the cuff impulse or the hernial swelling.
Okay,
So
sir.
there are situations where one should consider doing an investigation.
Yes, yes, sir.
So what investigation is superior, ultrasound or CT?
Sir,
Obviously,
for groin hernia, sir.
no, ultrasound is not superior. CT.
Okay, sir. Okay, sir.
CT gives you a good picture of the axial picture of the groin area.
Okay, sir.
Okay. So they are the indication for doing investigation for confirming diagnosis of hernia, not
Yes, sir.
in a situation where hernial swelling is seen, is reducible. There is no question of doing this. Okay.
Yes, sir.
What are the complications of hernia? Enumerate the complications.
So there can be local and general complications, sir. Local complications can be hemorrhage, sir. Then there can be
Not post-op. I am asking about complications of hernia.
complications of hernia, sir. Sorry,
Yeah.
complications of hernia, sir. There can be irreducibility, obstruction, incarceration, strangulation, and there can be hydrocele of the hernia, and there can be inflammation of the contents of the hernial sac.
Yeah. And if the hernia continues to grow, what happens?
The scrotal abdomen.
Total abdomen. Loss of domain.
Loss of domain, sir. Scrotal.
Loss of domain, total abdomen. Okay. How
Yes,
you
sir.
differentiate between a irreducible hernia and an obstructed hernia? What is the
Sir,
clinical differentiation between a irreducible hernia and an obstructed hernia?
Sir, features of obstruction will be there in case of an obstructive hernia, such as patient will be having acute pain abdomen, sir, may have accompanying vomiting and
Patient will
other
present with
symptoms.
abdominal pain in a obstructed hernia. Are you sure?
No, sir, as in sense
What
features
type
of
of
acute
what type of obstruction occurs in a obstructed hernia? What is the specialty of this obstruction? This is a closed loop obstruction.
okay, sir.
In a hernial obstruction is a closed loop obstruction where you have two obstructing points. Okay.
Yes, sir.
And this segment of loop of bowel is obstructed. So initially, patient may not have abdominal distension.
Okay, sir.
Patient may not have abdominal pain. The pain is confined to the groin area. And how is this pain?
Sir, it's a severe pain, sir.
It's a colicky pain.
Colicky, severe colicky.
Colicky pain initially, confined to the swelling, not generalized pain abdomen.
Okay, sir.
Okay.
Yes, sir.
And in both the situations, the hernia is irreducible.
Irreducible.
So patient may have other features of intestinal obstruction, constipation, vomiting. Okay, although vomiting is late.
Yes.
Okay.
Yes, sir.
How will you diagnose strangulation clinically?
So strangulation, sir, the swelling will be tense. It will be tender. There will be no cough. It will be tender, tense. Overlying skin changes might be there, sir, and so cough impulse will be absent, and it will be reducible, sir. And patient will be having tachycardia, tachypnea, sir.
Yes, general symptoms will be there.
Yes, sir.
Systemic symptoms.
How do you do a EHS classification for groin hernias? What is the EHS classification concept?
Sir, EHS classification for groin hernia, sir, there are three components that we see. First is whether it is a primary or the recurrent, that is P or R. Second is whether it's a lateral or medial or femoral, where it is given the identification as L, M, or F. And so then the third is the width. It can be 0, 1, 2, 3, NX. Sir, one is when the gap is when the defect is 1 finger or less than 1.5 less than 1.5 centimeters. 2 is 2 finger less than 3, and 3 is more than 3, equal to more than 3 centimeters or 3 finger defect, sir.
Yeah. So one should be very conversant about EHS classification,
Yes,
and for groin hernias, you should be knowing it, because now the standard of comparing is with EHS classification. Okay.
Yes, sir.
In hernia, what are the parts of a hernia? If you talk of a groin hernia, what are the
Yes, sir.
different parts of a hernia? What constitutes a hernia?
So there are 4 parts, sir. So the neck.
No, that is sac. I'm
Okay,
talking of hernia consists of sac and the contents.
okay, sir.
Okay.
Yes, sir.
Contents will vary. And now talk of
Milind,
sac. What are the
Milind?
parts of a sac?
Yes, sir.
Yeah.
Okay.
Yeah, Dr. Dash.
Yes. Milind, can you tell the situations when hernia may be strangulated without obstruction?
Strangulated without.
Strangulated hernia without obstruction.
Sir, litters hernia, sir.
Religious hernia.
Mhm.
Yes.
Before that,
Very simple. It may be omentocele. Okay.
Yes, sir. Yes.
Omenta may strangulate without features of obstruction. Any other thing?
a Richter's hernia may not cause
Yes.
classic
Yes.
obstruction.
Okay, sir.
Richter's hernia is a circumference of bowel which can get strangulated.
In
Yes.
strangulated.
Now, what will be your difference in approach of hernia repair in case of a strangulated hernia or uncomplicated hernia? In open, not laparoscopic.
Sir,
Suppose you are doing emergency, you got a strangulated hernia.
yes, sir.
How it will differ in approach?
Sir,
From your-
in case of a simple uncomplicated hernia, we will follow
Yes.
the steps as described in the. If you
Yes.
are doing a
Yes.
Liechtenstein tension tree, we'll follow the steps. Once we
Yes.
are able to once we are able to identify the cord, we will dissect the sac out, and we will reduce it, and we will repair the hernia. In case of
Okay.
strangulated hernia, sir, we will have to open the sac and see the strangulated portion. We'll have to see whether it is the omentum or the bowel, and we'll have to, if it is the bowel, we will have to look whether the bowel, this section of the bowel, it is still, whether it is patent or not. And if it is patent, then we can
Patent
reduce
means?
it. And if, sir,
Patent means?
sir, as in, sir, whether it's a so patent, as in, sir, whether it's a viable, sir, sorry, viable.
It is viable. Yes.
Viable,
But before
yes,
that,
yes.
you have to release the constricting ring. What is strangulating? That may be superficial ring or in the deep ring. You have to release somewhat.
Yes.
Okay. Then what will you do?
Sir, we will check for the viability of the bowel, sir. And sir, if it is viable, then we
What
can
are-
reduce.
What are the signs of viability?
Sir, the
What will be the color?
sir, the color is
In case of strangulation, it will be dark, blackish.
dark, yes, sir. So
Yes.
it will appear like dark and dead tissue, sir. But in case of viable gut, will be sir,
Normal
it'll,
pink color.
yes, sir, light pink color.
And anything else?
So peristalsis will be felt, sir.
Yes. There will be peristalsis.
Peristalsis.
And you can see the pulsation of the attached mesentery also.
Okay, sir.
So if it is a doubtful viability, then what will you do?
Sir, we will we'll put the patient on 100% oxygen, sir, and we will place a hot mop on on this particular loop of bowel, that is where the viability is in question, for about for some time, for about 2 to 5 minutes, sir, and we will see whether the bowel recovers or not, sir. Whether we can get the features of viable bowel or not, sir.
Okay, good. And you will try to, if you have to do a resection anastomosis, you have to go without mesh.
Yes.
You have to know the anatomy also. Your teacher may ask you, your examiner. But is Cooper? There are several methods of repair other than this Suldi's and Bassinis. It's called Cooper ligament. There is McVeigh's.
McVeigh's method.
Yes, repair. So you have to know where it is Cooper's ligament, where the lacunar ligament.
Yes, sir.
You have to know it. Okay. There is an thing laparoscopic. Yes.
So Sahasar is saying something. He's on mute.
Oh.
What is the contraindication of laparoscopic repair of hernia? Contraindication.
Sir, contraindication for laparoscopic repair is, places where we cannot dissect the preperitoneal space, such as patients who have undergone a preperitoneal surgery, such as for the one for a prostate. So then radiation, where the preperitoneal post-radiation patients where the preperitoneal space has already been
Other pelvic surgery.
Pelvic
Prostate,
surgeries.
other rectal vaulcopexy, or patient undergoing some gynecological procedures. So
Yes,
already a patient has a pelvic surgery, it's difficult to get the planes, the preperitoneal space.
Yes.
That is the important contraindication for laparoscopic repair. And next is hernia is irreducible.
Yes, sir.
If hernia is, now people are trying to do TAPP repair for even irreducible hernias, but reduced hernia is a relative contraindication.
Yes, sir.
For
And sir,
laparoscopic
if a patient cannot be put under general anesthesia, sir.
Yeah. So what are the different laparoscopic technique for hernia repair?
Sir, the TAP and the TEP, sir, total extraperitoneal repair, sir, and the transabdominal preperitoneal repair, sir.
What is the basic difference in this approach?
Sir, in case of the transabdominal preperitoneal repair, sir, we go from inside the abdomen. We open the yes, if we create a pneumoperitoneum and we open the flap of the peritoneum from the inside and we place the mesh. In case of total extraperitoneal repair, sir, we go between we go behind the rectus muscle and in front of the peritoneum. We dissect that space and there we place the mesh.
Okay, okay. Just little about a laparoscopic anatomy of the groin.
Yes, sir.
You find 3 ligaments. If you look from the back of the area, what are the 3 ligaments seen?
So there is the median umbilical ligament, the medial ligament, and the lateral ligament, sir.
They are formed by?
So the median is formed by the urachus, the medial is formed by the obliterated umbilical artery, and the lateral is formed by the peritoneal fold of the inferior epigastric artery.
So there are 3 fossae in relation to these ligaments. What are the 3 fossae?
So between the median and the medial, there is a suprapubic fossa. Between the medial and the lateral, there is the supravesical fossa. Sorry, supravesical fossa. Between the medial and the lateral, there is the medial compartment, and beyond the lateral to the lateral is the lateral compartment.
That is medial inguinal fossa.
Medial inguinal fossa.
Site for?
So for the direct hernia.
Yeah, and lateral
and
to that is?
Lateral to lateral is the lateral inguinal fossa, sir, site for the indirect hernia.
Okay. When you are operating with a TAPP repair,
yes, sir,
why do you start the peritoneal incision? Where is the peritoneal incision started?
At the ASIS, sir.
Yes.
2 centimeters, sorry, 2 centimeters middle to the ASI, sir.
It's close to
Yes.
ASIS. And if you take the hernial sac going to the deep ring, how far you will clear that area? You'll go through this ring or you'll go a little above?
So a little above, sir.
Yes. And how far you take the incision medially? It's clear that you should not go beyond that point. What is the middle
Sir,
incision?
the medial, sir, the medial ligament, sir.
Umbilical ligament.
Medial umbilical ligament, sir.
Sir, can you please repeat the question, sir? Couldn't follow.
This peritoneal flap is up to the umbilical ligament.
Medial
Clear?
umbilical. Yes, sir.
Why?
What is
Why?
height reach?
Why up to medial ligament?
Why?
What is there beyond that? If you take the incision further medially,
Bladder.
yeah, bladder. What is
Urinary.
lighthouse?
What is, sir?
Lighthouse.
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 What structure is called lighthouse during operative study? Because it acts
Once
as a
you are
lighthouse.
dissecting medially, you find the shining Cooper's ligament.
Oh, yes,
The
sir.
shining Cooper is described as a lighthouse.
Lighthouse. Okay,
What
sir.
is corona mortis?
Corona mortis is, sir, it is the abnormal branch of the obturator artery, sir.
Where it is? It can bleed and it can lead to
Yes,
death
sir.
also.
Sir, I'm
That's
not
the
sure about,
circle of death.
sir.
This is around the superior pubigrammas.
Okay, sir.
The area you are dissecting, the
Yes, sir.
Cooper's ligament,
Yes,
there
sir.
can be abnormal branch of obturator artery.
Obturator artery.
And that
Okay.
can be communicating with the main obturator vessel.
Okay, sir.
And if it bleeds here, it bleeds tremendously.
Yes.
Yes. So you should not press against or rub against the the iliopubic
Cooper's
duct.
ligament. Okay, sir.
Cooper's ligament. Cooper's ligament.
Yes, sir.
What is triangle of doom?
The triangle of doom is a triangle in this area, sir, that where the external um, uh, external inguinal vessels run, sir, and an injury in this area, sir, will cause massive bleeding, sir. It is boundaries.
He said is the area bounded by the vas medially,
Vas medially, the testicular vessels laterally,
the line joined to the base.
base, yes, sir.
External vessels are deep to this area. Okay, so it's 9:05. Any question from any other students? Any question we can answer? Any doubt regarding hernia presentation? Anybody can ask any question, any doubt. Hernia is a very important case for the DNB and MS examination. So you should be presenting the history well, do a good clinical examination, be ready with some method demonstration. So if there is no question, Dr. Das, we can conclude. Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, Milind.
Thank you, sir.
Thank you.